Uh, okay. So, so the American Society of Echo updates, and what they're saying, the quantification of cardiac chamber size and function is the cornerstone of cardiac imaging, with echo being the most commonly used non-invasive modality because of its unique ability to provide real-time images of the beating heart combined with availability of portability. Um, what we're saying is that if you can evaluate the left ventricular size and function, it gives tremendous information in terms of uh, prognosis. So if there's any ailment of the heart, you know, well, any ailment of the heart will affect the heart's function. So if you can evaluate uh, the function and size, it gives you a lot of information. So we can use echo to do that. And standardization of the methodology used to quantify cardiac chambers is maintained by creating and disseminating official recommendations, which, when followed by practitioners, provide uniformity and facilitates communication. So, of course, we all follow the American Society of Echo guidelines. There are other guidelines, but the one that you should follow is the AAC. Recommendations for the echocardiographic chamber quantification were last published in '05 by the American Society of Echo and the European Association of Echo, renamed the European Association of Cardiovascular Imaging. Since then, echo technology has continued evolving, with two major developments being real-time 3D echo, that's three-dimensional echo, um, and myocardial deformation imaging. So when we talk about myocardial deformation imaging, remember we're talking about strain rate, velocities, and stuff like that. And okay, so um, those are some of the things we're talking about when we talk about deformation. But three-dimensional echo has come into vogue, so we have to incorporate that in our armamentarium, echo armamentarium, that is. So the goal of this document is to provide an update to the previously published guidelines, as well as recommendations and reference values, while eliminating the minor discrepancies that exist between the previous guidelines. So, minutiae, want to get rid of that. The normal values in this update include three-dimensional echo and myocardial deformation when possible. Importantly, compared with previous guidelines, this update is based on conserving larger numbers of normal subjects compiled from multiple databases to improve the reliability of the reference value. So they use a lot more patients. Almost So although most issues covered in this document reflect a broad consensus among the members of the writing group, one important issue the group debated was partition values of severity of abnormality. Most often, in addition to describing a parameter as normal or abnormal, they give reference values. Clinical echocardiography qualify the degree of abnormality in terms of mild, moderate, and severe. So that's how we usually classify. Okay. All right. Which reflect the degree of which measurements deviate from normal. So, we usually talk about mild, moderate, or severe abnormality. In addition to providing normative data, it would be beneficial to standardize cutoff for severity of abnormality for all parameters. We're not going to belabel these. They're just basically telling you how they go about dividing the categories, it's best to show you an example. So again, the update is for the left ventricle. So the measurements for LV size. So measuring LV size is crucial. Okay, so the most commonly used parameters to describe LV cavity size include linear internal dimensions and volumes. So knowing how to measure these dimensions and volumes is very important. So measurements are commonly referred for end diastole and end systole, which are then used to derive parameters for global LV function. So again, we use end diastolic measurements and end systolic measurements to allow comparison among individuals with different body size. Chamber measurements, it should be reported index to body surface area. So basically, because you have different size individuals, and if you have a little lady and or LV cavity, say you're using linear measurements, and it is end diastolic is say 3.2, and she weighs 100 pounds, and then you have a guy who is 450 pounds and his LV measures 6.2. It might be the 6.2 might be normal for the bigger guy, and the 3.2 may be normal for the small patient. So it's best to index measure. You're going to see that they index a lot of the measurements. Basically, you divide whatever measurement by the body surface area. All right, so look at some of the linear measurements. It is recommended that linear internal measurements of the left ventricle and its walls be performed in the parasternal long axis view. So again, remember when we say we're doing measurements in our parasternal long axis view, we do these measurements at end diastole, okay? Values should be carefully obtained perpendicular to the LV long axis and measured at or immediately below the level of the mitral valve leaflet tips. Okay, we always stress that. The measurement should be perpendicular to the LV long axis. Okay, and you should measure at the mitral leaflet tips. In this regard, the electronic caliper should be positioned on the interface between the myocardial wall and cavity, and the interface between the wall and the pericardium. We'll show you examples. Internal dimensions can be obtained with a two-dimensional echo or two-dimensional guided M mode. So you can do the M mode is basically recommended to do two-dimensional measurements, but if you're going to do M mode, it should be two-dimensional guided M mode. Although linear measurements obtained with two-dimensional echo images are preferred to avoid oblique sections of the ventricle. So let's quickly look at these linear measurements. And so this is what we're talking about, okay? And the measurement, so the LV long axis is, okay, so let me draw this because it's very important. And even though I teach this over and over, I still see incorrect measurement. The LV long axis is like this, okay? Long axis of LV is like this. So this measurement is perpendicular to the LV long axis, measured at the tip of the mitral leaflets, okay? It's an end diastolic measurement, so you measure the onset of the QRS, okay? Septal thickness, LV internal cavity size in diastole and posterior wall. So linear internal measurements of the LV should be acquired in the parasternal long axis view, carefully obtained perpendicular to the LV long axis. This is very important. This is the LV long axis, and this should be perpendicular to it and measured at the level of the mitral leaflet tips. This is the mitral leaflet right there, measurements at the tips. The electronic caliper should be positioned on the interface between the myocardial wall and the cavity. So, okay, so this is the septal thickness. So right at the interface between the myocardial wall and the cavity, and you just come down, okay, and they're perpendicular. So the septum, LV cavity, in diastole, and and uh, and the posterior wall. Now, as mentioned before, you can do, even though we don't encourage it too much, you can do M mode measurements, but it should be two-dimensional guided, and then you put your cursor, so the measurement should be perpendicular to the walls. So your cursor should be perpendicular to whatever structure you're going to measure, and then measurement is done at the onset of the QRS. So this would be LV internal dimension in diastole. Okay, so even though you're probably not going to be tested too much on M mode, you need to know a little bit about it. Okay, so that is the all right. So what about the volumetric measurements now? So volumetric measurements, LV volumes are measured using two-dimensional echo or three-dimensional echo. Volume calculation derived from linear measurements may be inaccurate because they rely on the assumption of a fixed geometry of the LV shape, such as a prolate ellipsoid, which does not apply in a variety of cardiac pathologies. So it's best to use volumetric measurements as opposed, use LV volumes using calculations from volume measurements as opposed to linear measurements. Accordingly, the T-Coles and the Quinone methods for calculating LV volume from LV linear dimension are no longer recommended for clinical use. So I stopped teaching the Quinone and the T-Coles methods because it's not recommended. So we don't want to do stuff that's not recommended. Volumetric measurements are usually based on tracings of the interface between the compacted myocardium and LV cavity. So essentially you're going to plane the border, as we have shown you numerous times. We'll come back to that. And again, at the mitral valve level, the contour is closed by connecting the two opposite sections of the mitral ring with a straight line. We're going to show you that. It's just basically tracing the endocardial border. LV length is defined as the distance between the bisector of this line. That's the line at the mitral annular level. So the LV length is defined as the distance between the bisector of this line and the apical point of the LV contour. We're going to show it to you, which is most distant to it. The use of the longer LV length between the two apical and four-chamber views is recommended. LV volume should be measured from apical 4 and 2-chamber views. Okay, so if you're going to do LV volume, it should be apical 4 or apical 2-chamber views. Two-dimensional echo imaging image acquisition should aim to maximize LV areas. So you want to make sure that your LV is maximally I don't want to say distended, but maximally open. You don't want to foreshorten. So try and avoid foreshortening of the LV, which results in volume underestimation. So make sure you open the chamber adequately. Okay. Acquiring LV views at a reduced depth to focus on the LV cavity will reduce the likelihood of foreshortening. So basically, increase the size. When you're doing any type of measurement, increase the size. That's basically what they're saying. And minimize errors in the endocardial border. Because the issue of foreshortening is less relevant in three-dimensional data sets, three-dimensional image acquisition should focus primarily on including the entire left ventricle within the pyramidal data set to ensure reasonably accurate identification of end systole. The temporal resolution of three-dimensional imaging should be maximized without compromising spatial resolution. Whenever you see any question and they're talking about volume and 3D is mentioned, 3D is the most accurate method for measuring volumes. So remember that. Contrast agents should be used when needed to improve endocardial delineation. When two or more contiguous LV endocardial segments are poorly visualized in apical view as per published guidelines. So if two or more contiguous LV endocardial segments are poorly visualized, you can use microbubbles or contrast agents. And it should be, in this day and age, it should be readily used if you cannot identify two or more contiguous LV endocardial segments. Contrast enhanced image may provide larger volumes than unenhanced image that are closer to those obtained in cardiac magnetic resonance in head-to-head comparisons. So care should be taken to avoid acoustic shadowing, which may occur in LV basal segments in the presence of high concentration of contrast. So essentially, if you have a suboptimal image, use contrast. The most commonly used method for two-dimensional echo volume calculation is the biplane method of disk summation or the modified Simpson rule. Okay, this is another exam question. Okay, the most commonly used method or the recommended method is the biplane method of disk summation or the modified Simpson rule, which is a recommended two-dimensional echocardiographic method by consensus of the committee. An alternative method, however, to calculate LV volumes when apical endocardial definition precludes accurate tracing is the area length method, in which the LV is assumed to be bullet shaped. So that's an alternative method not recommended by the committee. The mid-LV cross-sectional area is computed by planimetry in the Parson Shorter. I'm not going to go over this because I don't want you guys to memorize this and then, forget about the biplane method of this. The shortcoming of this method, however, is that the bullet shape assumption does not always hold true. One of the advantages of three-dimensional echocardiographic volume measurements is that they do not rely on geometric assumption. And that is why it's more accurate than two-dimensional volume measurements. In patients with good image quality, three-dimensional echo measurements are accurate and reproducible and should therefore be used when available and feasible. The advantage and disadvantage of the various methods are summarized. So let's have a look at how we do our measurements of our, okay, so for volume measurements with our LV, So we look at the linear measurements already. Okay. So again, if you're gonna do volumes, you can either do the 4-chamber or the 2-chamber. Okay. Volume measurements are usually based on tracing of the blood tissue interface in the apical 4 and 2-chamber view. So we usually see people curving and going and going. No, you're tracing the endocardial border. So in end diastole, that's how the onset of the QRS. You come up and you trace the border, okay, the blood tissue plane, and then you come down. You come down to the base of uh, uh, the mitral valve, and once if you start here and you finish here, then the the computer will complete the basal line. Okay. Okay. So um, so you will just the it will complete the basal line. So to get this measurement, it's at the midpoint. So at the base, the midpoint, and you're going to go straight up to the apex. Okay. So from the midpoint right there straight up to the apex, and then in systole, okay, you're going to trace the border. If you start here, you just trace the border, okay, and once you stop here, it will complete the basal line, and then you're going to go from the midpoint at the mitral annular level up to the apex, okay. So at the mitral level, at the mitral valve level, the contour is closed by connecting the two opposite sections of the mitral ring with a straight line. Okay? So, and usually the computer will close that for you. LV length is defined as the distance between the middle of this line, the middle of the line, okay, and the most distant point of the LV contour. So you're going to go, to the apex, to the most distal. And then once you do this, the computer will give your diastolic volume measurements, and it will give your LV systolic measurement. Okay, and you remember the ejection fraction, which a computer will do for you, is N diastolic volume minus N systolic volume divided by the N diastolic volume. So you can do it in both the 4-chamber or the 2-chamber. Okay, the biplane method of disc or the modified Simpson rule. Okay. Um, Again, the area length method can be used, but it's not the recommended method. All right. So normal reference values for our two-dimensional echo. So these are the numbers that you need to remember. So data were extracted from 7 databases, including the ASCLIPS year 0 to year 10. Okay, they go through all the different methods. All data were obtained without the use of contrast agents, so they didn't use contrast. Data sets for all patients included the age of the patient, the gender of the patient, the ethnicity, the height, and weight to ensure a normal population. Because what they're doing, they're going to separate, male, female, and not only male, female, but different ethnic group and give normal values for these groups. To ensure a normal population, subjects in these studies were included if any of the following criteria were met. So if they have a systolic blood pressure greater than 140, diastolic blood pressure uh, greater than 80, so they were excluded. So basically, they want to exclude patients who were so-called not normal then. So because we're talking about normal values. So if the patients were hypertensive, systolic blood pressure greater than 140, diastolic blood pressure greater than 80, they didn't use them. If the patient have a history of drug-treated hypertension, diagnosis of diabetes, impaired fasting glucose greater than 100, body mass index greater than 30 kilogram per meter square, creatinine greater than 1.3, GFR less than 60. So essentially, they just want to use so-called normal individuals. Because of varied study aims, not all echocardiograph measurements were available for each database. Okay, so they tried to make the population as normal as possible. So, and we're gonna look at the different um, values and the range. Um, they gave it for the LV dimension, that's the size of the LV, for the LV volumes, ejection fraction, and the mass. Okay, of course they use the age of the patient again, the gender, and body surface area. So what I'm going to do is just show you the table of measurements, and because essentially you just have to know the normal values. Okay, all right. So, and of course they use the cardiac MR as a guide. The effects of ethnicity on three-dimensional echocardiographic LV volumes were investigated in one study, which reported that LV volumes were smaller among Asian Indians than white Europeans. Okay, so they're comparing different ethnic groups, and you know that's what it showed. But EF did not differ among ethnic groups. So even though the LV volumes appears to be smaller for Asian Indians than white Europeans, the ejection fraction did not differ. In most three-dimensional echocardiographic studies, the relationship between age and 3D LV volume was examined, and weak to moderate negative correlations were seen between age and LV volume, while EF did not change significantly with age. Um, Three-dimensional echo volume, LV volumes, were larger than, so the three-dimensional echo LV volumes were larger than the two-dimensional echocardiograph values, because again, remember, with two-dimensional echo measurement, you do a lot of assumption, whereas three-dimensional, you don't have to do that. All right, so let's look at the recommendations. Okay, so we just gave you some of the, so LV size should be routinely assessed on two-dimensional echo by calculating volumes using the black. So these are what you're going to be tested on, okay? So even though we gave you some extra information, this is what you're going to be tested on. LV size should be routinely assessed on two-dimensional echo by calculating volumes using the biplane method of disk summation, the modified Simpson rule. In labs with experience with three-dimensional echo, three-dimensional measurement and reporting LV volumes is recommended when feasible, depending on image quality. So if you have access to three-dimensional technology and you can use it, then use it because it's more accurate. When reporting LV linear dimensions, the recommended method is 2D guided measurements. Okay? LV size and volume measurements should be reported indexed to body surface area. So it is currently recommended that when you talk about LV size and volumes, it should be indexed. And if you're doing any current exams, they're not going to have any absolute values. It's going to be an index value. So you have to be familiar with it. So for general reference, two-dimensional echocardiographic LVN diastolic volumes of 74 mLs per meter square for men and 61 mLs per meter square for women, and LV end systolic volume of 31 mLs per meter square for men and 24 for women should be used as the upper limits of the corresponding normal range. Again, especially for people who are doing exams, you're not going to get any absolute volumetric measurement. It's going to be index. That means they're going to divide it by the body surface area. So for males, if the end diastolic volume, the upper limit is 74 mLs per meter squared. And for females, it's 61 mLs per meter squared. And then the end systolic volume is 31 for males and 24 for females. Those are the upper limits. Okay? So you have to try and get that concept squared away. Now, global LV function is usually assessed by measuring the difference between the end diastolic and the end systolic value of a one-dimensional 2D or 3D parameter divided by its end diastolic value. So that's the ejection fraction. We went over that. So if you want to talk about global systolic function, that's how you do it. For this, the end diastole is preferably defined as the first frame after mitral valve closure. So as soon as the mitral valve closes, that's end diastole. It usually corresponds to the onset of the QRS, or the frame in the cardiac cycle in which the respective LV dimensional volume measurement is the largest. So if you don't have a ECG capability, then you can just look and see where the LV volume is the largest. Okay, but basically end diastole, remember now, with diastole, the mitral valve closes, and then at the end of in diastole, the mitral valve opens. At the end of diastole, the mitral valve closes. So end diastole, the mitral valve just closed. So once you're scrolling through, you can see where the mitral valve just closed, and that's end diastole. Okay, or you can look and see where the volume is the largest. End systole is best defined as the frame after the aortic valve closes, because systole, the aortic valve opens, and then at the end of systole, the aortic valve closes. Okay, so you can use the frame after the aortic valve close, or the frame in which the cardiac dimension or volume is smallest. So again, at end systole, you have maximal contraction, so you should have the smallest volume. And end diastole, you have maximal fill-in, so you should have the largest volume. In patients with regular heart rhythm, measurements of the timing of valve opening and closure derived from M-mode echo, pulse, or continuous wave Doppler may be used for accurate definition of ventricular time interval. Basically, most of us use the ECG as a gated thing, but if you're having problem, you can just look at the maximum volume and the minimal, the smallest volume. We talk about fractional shortening as a measure of systolic function. Okay, so fractional shortening, it can be derived from 2D guided M mode, so you can use your M mode method to measure fractional shortening, or you can preferably from linear measurements obtained from 2D images. Okay, so it is preferable to use your 2D images, but you can do it from M mode. You're going to derive global LV function parameters from linear measurement. It is problematic. So, it's more of a historical thing than something that we currently do. And so you need to know how to do it essentially. Um, all right, so let me just go back a little bit. All right, so and we of course everybody knows the formula for ejection fraction. N diastolic volume minus N systolic volume divided by N diastolic volume. Okay, that's ejection fraction. For fractional shortening, essentially just a linear measurement. We're not gonna go over strain because some people have not done strain as yet, so we're not gonna mention that too much. All right, so let's look at our table. So this table is very important. So these are our linear dimensions. So, and of course they divided into male and female. So we're talking about for LV internal dimension in diastole, okay? It is for males, it is 50.2 plus or minus 4.1, okay? This is linear dimension. And for females, it is 45.0 plus or minus 3.6. For systolic dimension, for male 32.4 plus or minus 3.7, okay, systolic dimension. And then again, the thing is to use it's best for you to use the index volume, okay? So LV volume normalized by body surface area for males, their end diastolic volume 54 plus or minus 10, okay? And the systolic volume is 21 plus or minus 5. For ejection fraction, for male, using the biplane method, it is 62 plus or minus 5. Okay? And these are the range that they give you for the different values. And then for females, the ejection fraction 64 plus or minus 5, and this is the range. So these are the current values and the range. So what you can do is put these up in the lab so that you don't have to memorize it, or you can modify your echo sheet to reflect these values. So again, if you're going to do so what was we showed you before is with two-dimensional echo. Okay, for three-dimensional echo, it's different. Okay, it's different for three-dimensional echo. So if you're using three-dimensional echo, then you have to use these values. Okay, for men, it is the mean is about 57 for women, 61. So, but, okay. All right. So we also talk about regional walls. And just to recap the regional walls, and the reason for doing the regional walls because it gives us information about the blood vessel that is involved. If there's a wall motion abnormality, um, it helps us to determine the blood vessel that is involved. So, depending on the regional coronary flow reserve, stress echo may reveal significant coronary artery stenosis by means of inducing a wall motion abnormality. Myocardial scar may also result in regional dysfunction. So when we do our stress tests, we can look at the regional wall and determine which area is not moving well, and as a result, the blood vessel that's involved. And so if we are using a 17 segment model, of course, the 17 is your apical cap. Just outside of that, you have the apex, anterior wall, inferior wall, lateral wall, and the septum. This is the mid cavity level, anterior, inferior, lateral. So this is the anterior lateral, inferior lateral. This is the septum over here, inferior septum, anterior septum. And this is the outer one is the basal, at the basal level. So you see anterior, inferior, lateral again, anterior lateral, inferior lateral. Over there is your septum, anterior septum, inferior septum. Okay, and as we showed quickly, um, the anterior in the septum is usually LAD. Over here is usually the circumflex or a branch of the LAD. Inferior is usually the RCA. So this is just a rough guide. So if you have an abnormality in a specific segment, you can determine which vessel is involved. So that's the importance of regional walls. So the of course this just of course you guys know this, so we can if this is an apical 3 or long axis 2-chamber 4-chamber, we divide it into segments as well. So again, for the 4-chamber view, this is our lateral wall, okay, or your anterior lateral wall, and this is your inferior septum. Close to the mitral valve is the basal level. So this is your basal anterior lateral mid, where you have the papillary muscle, and then the apical lateral wall. This is your inferior septum, your apical, your mid, and your basal. Okay, and then your 2-chamber view. Okay, again, this is the anterior wall. This is the inferior wall. So anything close to the mitral valve, basal, mid, apical, anterior wall. Then the inferior wall, basal, mid, apical. And this is the long axis, or your apical 3. So this is your anterior septum and your inferior lateral wall. And you divide the same way. Your basal, mid, apical. Okay, so you need to have a good understanding of the different segments, have an idea of the blood vessels that supply those segments, so you can, especially those people who are doing an exam, they're gonna, and of course, they normally, when you get a polar plot, so this is what we call a polar plot. So when you get a polar plot, if they give you in the exam, they give you a polar plot, the number that they put inside the polar plot is going to represent whether it's hypokinetic, akinetic, or normal. Remember, normal get a score of 1, and when we say normal, you have normal thickening with contraction. If it's hypokinetic, you get a score of 2. And if it's akinetic, it's get a score of 3. So what they'll do is probably put the number inside there, and then probably ask you what segment is akinetic, and then probably ask you which blood vessel is most likely involved. So multiple ways they can do it. Okay, so that's okay. So again, don't get it too complicated. So the anterior wall and the septum is LAD, anterior wall, septum towards LAD, and then over here is usually the left circumflex or a portion of a branch of the diagonal. Lower down is the RCA. The RCA is usually inferior, and then if you use your four chamber view, so over here is usually a branch of the LAD or the circumflex. Apex is usually the LAD, the septum usually the LAD. So you don't have to. And again, these are just guidelines because patients going to differ and blood supply may differ quite a bit. So you just need to have a rough idea because all right. But the new value that we talk about, and most of us use two-dimensional echoes. So those values you need to so this doesn't want to get any larger. But so we went over it at first. So anyway, so for two-dimensional, know the current ejection fraction for male and female. You see, it's different, and they like to bring the volume for some reason. They like to see if you know the LV end diastolic volume measurements. Okay, so those are the guidelines. Know how to do your measurements. Because a lot of time when you do the exams, they want to make sure that you are a good technician. You just know what to do. So it's not going to be anything, difficult. It's just stuff that you should be doing all along. Okay, so